Geriatric Syndromes, Dementia by Erica Bennett. Introduction to Dementia. Dementia is the loss of cognitive functioning, thinking, remembering, reasoning, and behavioral abilities to such an extent that it interferes with a person's daily life and activities. These functions include memory, language skills, visual perception, problem solving, self-management, and the ability to focus or pay attention. There are several types of dementia, including Alzheimer's disease, vascular dementia, mixed dementia, and dementias associated with brain injury, alcohol abuse, and infection. Alzheimer's disease accounts for the majority of cases in dementia, with 60 to 80% of cases, and vascular dementia is the second most common type of dementia. Dementia is usually a slow progressing disease that is caused by the death and damage to neurons in the brain. In 2015, about 47 million people globally were living with dementia, and this number is projected to triple by 2050 due to the rising population of older adults. In 2015, the global cost of dementia was estimated to be about $818 billion. Nearly 85% of costs are related to family and social care. Risk factors for dementia include older age, family history, a personal history of cardiovascular or cerebrovascular disease, diabetes, midlife obesity, use of anticholinergic medications, and lower educational level. Dementia affects about 5 million adults in the United States and is the fifth leading cause of death among Americans older than 65 years old. Subjective data. It is important to obtain a thorough history from a reliable source because the patient can have an poor insight to their own condition. History should include education level, timeline of symptom presentation, and speed of progression. Early disease can affect ADLs such as paying bills, balancing a checkbook, or remembering to take medications. Disease progression can further affect ADLs and IADLs such as eating, bathing, dressing, toileting, transferring, continence, and walking. The typical presentation and common complaints from someone with dementia include memory loss that disrupts daily life, challenges in planning or solving problems, difficulty completing familiar tasks, confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words or speaking and writing, misplacing things and losing the ability to retrace steps, decreased or poor judgment, withdrawal from work or school activities, changes in mood and personality. The presenting patient in this case is an 85-year-old Caucasian female who presents with her daughter today with complaints from her daughter about intermittent confusion over the last 2 months. She reports that her mother cannot recall who she is some days and is convinced that they have moved homes. She also states that her mother woke up last night in her own home yelling about how they were putting her in a nursing home. The patient is wheelchair-bound and does not desire to be mobile, so she is becoming increasingly weak and requires assistance for all ADLs and IADLs. The patient states that she does not remember doing anything that the daughter is saying and feels that she has had a good week. She has no allergies. She is currently on medications including lisinopril, Lexapro, omeprazole, aspirin, and metformin. She's up to date on immunizations, up to date on her mammogram and colonoscopy. Past medical history includes diabetes type 2, hypertension, anxiety, depression, and GERD. Review of systems, she reports fatigue and weakness. She denies fever, chills, falls, and pain. She denies chest pain, palpitations, swelling, syncope, and shortness of breath. She does report weakness and unsteady walking. She denies any trauma, foot problems, or dysfunction of her extremities. She reports forgetfulness, behavior changes, aphasia, and unsteadiness. She denies dizziness, dysphagia, visual disturbances, paresthesias, or sensory changes. She does report anxiety and insomnia and denies depression and loneliness. Physical examination findings are often normal in patients with dementia. It's important to review all medications that may affect cognition. Recent hospitalization should increase suspicion for delirium. Ruling out other potential causes for cognitive decline is important. Hypothyroidism, depression, hypoperfusion from heart failure, vitamin deficiencies, neurosyphilis, intracranial tumors, and normal pressure hydrocephalus should all be ruled out. Mental and functional assessments can help determine the cognitive decline. Labs to rule out anemia, hypothyroidism, vitamin B12 deficiency, diabetes, liver and kidney disease. Testing for neurosyphilis and HIV should be reserved for patients with risk factors. Neuroimaging is recommended. MRI is recommended over a CT scan due to increased sensitivity. Her vital signs were all normal. She was well appearing. She was obese. She did come into the office by a wheelchair. She was alert and oriented ×2 and in no distress. Her cardiovascular status was normal. Neurologically, she was alert and oriented ×2. She had some mild weakness noted in her bilateral upper and lower extremities. She was able to stand but was very weak. She had full range of motion in all extremities. The screening tools used were the Tenetti Gait and Balance Scale, which indicated high fall risk, the Global Deterioration Scale for Primary Degenerative Dementia indicated mild dementia, the Zarit Burden Interview was a score of 56, which indicated severe burden to her caretaker, which would be her daughter. The Caregiver Strain Index indicated high level of stress for her caregiver. The Mini Mental Status Examination was indicative of cognitive impairment, and the Mini Cog was indicative also of cognitive impairment. The plan for this patient, the differentials to rule out were delirium, a UTI, hypernatremia, and hypothyroidism. A full health history was completed. Labs were also ordered, including a CMP, CBC, thyroid, vitamin B12, and A1C and a urinalysis. Neuroimaging was ordered as well, which was the MRI brain without contrast. The final diagnosis for this patient was unspecified dementia with behavioral disturbance. Currently, no treatment exists to stop or slow dementia caused by neurodegenerative diseases or progressive dementias. Drugs such as donazepam, rivastigmine, and galantamine can temporarily improve or stabilize memory and thinking skills in some people. In this patient, no drugs were ordered. Community resources include home health. Her daughter was having to return back to work in a few weeks, so she was requesting home health to come in and assist in the home. Adult daycare programs and respite care services are also available. A doctor, nurse practitioner, registered nurse, physical therapy, occupational therapy, and social work may be involved in this patient care. Health behaviors in this case that were discussed: she did not drink alcohol, smoke, or use illegal substances. She does need to attempt being more mobile and exercising. A lot of her weakness seemed to be a behavioral issue and her just not wanting to do anything. She did eat fairly well per her daughter. Social determinants of health were low income, limited transportation, and limited surrounding family to help. Socioeconomic issues include loss of independence and cost of caregivers, therapy, and transportation services. And legal and ethical issues to consider involve a power of attorney, which if she is diagnosed with dementia, she will have to appoint a POA. An end of care life and code status should also be discussed. In conclusion, dementia is a common and widespread disease with a poor prognosis. There's no cure for dementia, therefore the focus should remain on prevention. And there are multiple forms of dementia that can be managed and treated differently. Dementia is not a normal process of aging.